couple of disclosures. I don't consider myself an expert in cystic fibrosis, so that's the first one. Second, I don't have any conflicts of interest. Basically, why I'm giving this lecture is based off on my prior experience. When I was a fellow, I was never interested in doing cystic fibrosis, and I didn't think I was going to be seeing these patients on a regular basis. I signed a contract with my first employer, and within 3 months they signed a contract with the cystic fibrosis program, where I started working for us to staff the adult program. So we were basically forced into seeing these patients, and by the experience and what I had to read about and what we had to deal with our own residents when we were there, I thought it was going to be a good idea for you guys to get a version of somebody who considers himself a general pulmonologist about how to treat cystic fibrosis. I did a staff cystic fibrosis program for a little bit over 2 years, and it was a really good experience. And I'm just going to go over things that I wish I would have known when I came out of fellowship about cystic fibrosis. Okay. So this is the outline. I'm going to go a little bit over introduction, pathogenesis, why has the cystic fibrosis concept and overall survival improved. I'm going to talk mostly about the treatments available for the pulmonary disease in cystic fibrosis, go over what a usual outpatient cystic fibrosis visit is, which most of us, or at least when I was in training, I was not exposed to that. A little bit of an overview of acute exacerbations, including care as an inpatient, and some technicalities that nobody tells you that probably you should be aware of. So, as everybody knows, it's a multi-system disorder. Basically, there is a mutation in the chromosome 7, and it's considered the most common life-threatening autosomal recessive disease in Caucasian populations. What causes the disease? There is basically a defect in the gene in the chromosome 7. What happens is, this is the left side of this picture is what normally the CFTR receptor does, and what happens in cystic fibrosis. So what happens, the receptor helps to pump chloride out of the cell, making the influx of sodium lower, and basically the main issue is water remains out of the cell. This is the lumen, basically keeping the secretions well hydrated. What happens in cystic fibrosis is that the receptor somewhat is not working, and there are many mutations described, over 1,000 of them, leading to an increased influx of sodium within the cell. And as you know, water always follows sodium, and that leads to thickened secretions, and that leads to a cascade of problems. This is another way of seeing what I just showed. What basically happens is chloride stays within the cell, and the receptor does not function, or it's abnormal. What happens afterward? This is a schematic view of what happens. Normal epithelia showing the ciliary surface, the secretions, how they move, the gradient of oxygen, and these are your cells. What happens in cystic fibrosis, the secretions are thick, they don't move, all the cilium is not very useful, and eventually the mucus thickens, the gradient of the oxygen changes. This mucus becomes chronically infected, not colonized. That's one thing that all the CF experts talk about. This is not colonization, it's a chronic infection. And this also leads to neutrophilic inflammation, a chronic inflammation, leading to destruction and bronchiectasis. Another scheme about the organs that the disease affects. So remember, it's a multi-system disease. We deal mostly with the lungs because that's the organ system that gets affected the most and actually takes away the life of these patients most of the times. But other important compromises are pancreatic insufficiency, both exocrine and endocrine. The GI issues that we see a lot with constipation, and the chronic sinusitis are the biggest ones that you may have to deal as a pulmonologist. These are the bronchiectasis that are seen in cystic fibrosis and leads to the typical pattern of obstruction. Feel free to stop me if there are any questions at some point. So what has changed with CF?
As you were showing that, I was thinking something that I've always known but I never thought about. What is the relationship between the chloride receptor and ciliary, this lack of normal ciliary function? How are they related?
Great question. I did not review that in depth, but what I understand basically is the ciliary function is not compromised. What happens is it's ineffective due to the quality, the physical quality of the secretions.
So the azoospermia is the same issue. It's not the lack of.
No, it's basically the conducts do not work and eventually become inflamed, and they just there's a functional azoospermia from that. But I can get back to you on that. I didn't review that in depth. So this was one of the older publications, 1996, showing how the survival of CF has changed in the last century, I should say. And this is more recent data from the CF Foundation showing your median predicted survival age, how that has changed, and now we're getting patients in the 40s and even 50s. But why? So this is an overview of how the treatments and the discoveries evolved in the 50s. And basically, one of the paradigms was started with the Airway Clearance and family-centered care when they started doing more respiratory therapy at home for these kids. Then they started enzyme replacement and started talking about the importance of weight. And overall, there has been a progression, a slow progression in all the discoveries and treatments. And it is important to note that the role of parents and families pushing for this through the CF Foundation has been really important. They are the ones giving the grants and helping to discover more drugs. So basically, you can see the correlation between the implementation of new treatments and the improvement in survival. That led to also some CF care paradigms that everybody talks about. The most important one is a coordinated care. It's not only a physician-centered care, it's a multidisciplinary care. And that is seen mostly in the outpatient setting when you basically, the patient is seen in every single visit by 3 or 4 disciplines. The pulmonary care has been optimized, and I'm going to go over the therapies that have been described. Education from both the patients and families. Nutrition is also important, and I will show you how the BMIs correlate with the survival of these patients. Reproduction and other, but pretty much education and pulmonary care are the most important ones. So getting to the matter of the fact here, the components of pulmonary care. And I try to make it as schematic as possible to classify them because there are many medications involved in the treatment of pulmonary disease. So basically, there have been different targets identified as potentially helpful to treat these patients. One of them, the first one, is the defective receptors, and there have been development of new medications targeting the defects of these receptors, making them more functional. I'm going to go over them. Second is ion transport, and I just mentioned that, but there has been no change or medication or therapy that has changed the transportation of ions in terms of sodium chloride to change the thickness of the secretions. there has been a lot of improvement in the airway clearance techniques and medications to support that. Chronic colonization and chronic infection with antimicrobials. I will go over the ones that are used chronically. And inflammation. What has been done and what is recommended for inflammation. So modulators of the cystic fibrosis receptor. Basically, there seem to be correctors and potentiators. The potentiator is a medication that will help open the channel if this is defective. And there is only one FDA-approved medication as a potentiator. And the other one is the corrector. Corrector means the medication works at the intracellular level to make the molecule functional. And this usually is paired, the corrector is usually paired with a potentiator. And that's the case of the Orkambi. Orkambi was studied or approved for patients with the most common deletion, the deletion in the 508 part of the gene. And this is a graph that shows the change in the FEV1 with two different dosages of the Orkambi compared to placebo. You can see the dramatic difference within a day, and it's sustained. The amount of pulmonary exacerbations after 24 weeks decreased dramatically, and the higher the dose, the lower the chance for exacerbations. So keep in mind, this is a corrector and a potentiator. The other one, it's just a potentiator for this mutation. And this was the first medication actually available to modulate the receptor. And one common thing that you're going to see in every single study of CFers are these graphs. Change in the FEV1 and change in the quality of life. Most importantly, your chances for exacerbation. They did it in an event-free mode in this study, and your BMI. So this is pretty much what CF centers, doctors, CF Foundation focuses on. Your change in FEV1 and your BMI. Bottom line, right now, what it's important for you guys to know is that there are two medications available that work on the receptors. The first one is Orkambi, which is approved for the patients that have both deletions of this mutation. And then there's the Calideco that is approved for the patients that have this mutation, the G551. I think it's likely that this may get asked in your boards, as these medications have been already out in the market. For you to know, this is what the CF Foundation calls the pipeline of all the drugs that are in development. So you can see both the Orkambi and the Calideco here. There is this one going into a phase 3 trial. I'm going to talk later about the Pulmozyme, Hypertonic Saline. They're studying the inhaled mannitol, and this is ibuprofen. So they support and they study a lot of patients, and that's one of the positive points about the CF Foundation. Yeah.
Is there a reason that potentiator only in that deletion and not other deletions?
I think so. If you see, let me see. They have been trying to use it in other deletions too.
But they want to stay. Literally, FDA is asking them to study it in every.
Yeah, I think right now that's kind of the standard potentiator. So if you are going to develop a medication that works as a corrector, you need to pair it eventually with that potentiator. But I think that's the only one that has been studied and gotten that far. But there are many more.
Who's got an unknown deletion or a different genetic defect, you can't use
No,
those drugs.
no. Actually, when Orkambi came out, we had to go back and see how many of our patients had the two deletions of the F508. and we got them started. And it's like $200,000 a year, so insurance companies will not approve it unless the deletion is there. Okay, that's about the receptors. One thing that I wanted, yeah, fine, please.
I have other questions.
Yeah.
So we were talking about this in clinic the other day, and I'm not sure, I don't know, you didn't talk about diagnosis. I realize a lot of these people are diagnosed before they see us, but so is the standard a sweat test, or is the standard a genetic, or both?
I didn't put on purpose the diagnosis here because most of the times they will be diagnosed when they get to you. The recommendation, last time I checked, is like a 2-tier type of thing. The first one, you need to do 2 sweat chlorides in sweat chlorides. Once that is confirmed that the level is higher than normal, then you proceed with the genetic testing.
I can do it at PSC.
And this wasn't that, is it at Children's?
I locally, I haven't.
We don't do that here. I had to send the patient to PMC.
One other thing I forgot to mention, with Orkambi, you don't only see the improvement in the FEV1 and respiratory issues, but also their diabetes gets much better, and the quality of life and endurance is better.
I think the sweat chloride is like the gold standard test that they routinely do, the genetic testing, because it's expensive and because the different phenotypes are only available at a couple, for the different genotype testing is only available at a couple of places. So
Correct.
I think everybody starts with the sweat chloride. The problem for us is that we're going to see, we're more likely, we don't see very much at all, but when we see a patient, we're likely to see that middle-aged bronchiectasis patient, and they can have equivocal sweat chloride tests, so that the test becomes then less useful for us, and then you have to send for the testing, which is what I've had to do in a couple of situations where even when you get the sweat chloride, it doesn't really help tell you that it's not that.
Yeah, there is an intermediate range that doesn't give you a real answer.
That's been my problem.
And if you have a strong suspicion, then the genetic testing becomes handy. The problem is that genetic testing, as I said before, there are 1,000 described mutations, and it only tests, depending on where you send it to, between 12 most common mutations, and there is an expanded panel that I think takes up to 50 of them.
There's only a couple places that do that.
Correct, and then insurance will give you grief about that. However, the CF Foundation, if you talk to them, they may be able to assist the patient to get the genetic testing if your suspicion is really high. But at that point, you need
Same
to...
problem, right?
Well, at that point, you probably would have sent the patient for evaluation to a CF center, and then they will take it from there. Okay, as I said before, ion transport, there is nothing developed. I just mentioned it because it has always been a potential target for therapy. In terms of clearance, that's probably the biggest and most studied portion on CF patients. Airway Clearance, so is the standard daily therapy for patients with cystic fibrosis, and again, because of the viscous airway secretions that lead to airway obstruction, infection, and injury and bronchiectasis, the goal is for them to keep mobilizing these secretions as frequently as possible. I don't know if anybody has read this article. Personally, when I read this article, I learned the most from CF from this article than any chapter or book. Basically, the author talks about the differences in care in the different CF centers and how it evolved from being like tents in the house with humidifiers to where we are right now. So if you guys have any spare time, I recommend this reading.
I think for anybody who treats chronic disease, we all do, it really is a great article to point out what you need to do to improve the care of patients who take care of every day. So
Yeah, and
whether it's COPD, PH, ILD, whatever, it's really a great article.
so for airway clearance, there are different interventions that have been described, and all of them are thought to be equally effective. There is no one that is thought to be better than the other. The chest PT is the accepted standard against which everything gets compared to, but that doesn't mean it's better. I'm not going to go over every single technicality. I just wanted to mention them because you guys may want to know about them. There's active cycle breathing, autogenic drainage, pulmonary, positive respiratory pressure and flutter valves, intrapulmonary percussive ventilation, high frequent chest compression, which is what they call the vest, and is the most common one, the one that the patients like the most because they don't have to do anything, just put the vest on and turn it on. And exercise. So exercise is considered equivalent as any of the other therapies for airway clearance. Usually, for that to be considered equivalent, it needs to be 30 minutes each session, and it needs to increase your heart rate enough so to be considered exercise and to be considered equivalent. Questions so far? So the recommendations say the airway clearance therapy is recommended for all patients with CF. There is no better or worse, and basically this is where every single patient has a different preference. Throughout the years, when they get to the age where they see you, most of them have settled down either with a vest or a flutter valve. In terms of medications for pulmonary clearance, you have the Pulmozyme, which is recombinant human DNAs, and it degrades the DNA that accumulates within the mucus. It's kind of a mucolytic. One more of those graphs showing the change in the FEV1. So improves the FEV1 and causes fewer exacerbations. So this is the arm of the DNAs and bigger change on the FEV1, and this is the placebo arm. Importantly, many centers or pulmonologists consider that once daily is equivalent to twice daily. Not necessarily true. Twice daily decreases your risk of exacerbations more than just once daily. So, again, in the rare case that you are following these patients and they are having frequent exacerbations, FEV1 is getting worse. One of the ways that we usually treat it was just go up on twice a day. Adverse events are minimal, and patients usually don't stop this medication as compared to, I will go over hypertonic saline. So basically it's recommended for every single stage by the CF Foundation, from mild to severe, to improve lung function and reduce exacerbations. Hypertonic saline, the rationale behind it is basically by putting more salt in your secretions, it will bring water and will improve the viscoelastic properties of the secretions, and that will improve your clearance. There is a myth out there that I have never been able to prove that basically surfers in Australia with CF used to do better in lung function, and then they thought it was from this exposure to the salt in the sea. So that's how this evolved. That's the myth. Whether it's true or not, I don't know. Again, another graph showing how it improves your FEV1, and another graph showing how it makes better your exacerbations. This is a common problem with patients with CF, is basically they complain of coughing after using this, and sometimes wheezing, because it may trigger or it may do bronchospasm, so sometimes they cannot tolerate it. But I think it's important, and actually we used both, the hypertonic and the Pulmozyme at the same time, and with good results. Yeah.
I forget now. I know I've tried to order it for a patient or two, and I can never get 7% saline. Did you guys have to get it out of the CF pharmacy, or could you get it from regular pharmacy?
The problem is that most of the softwares like Cerner and Epic do not routinely put it in their order set.
That's the other thing. Is it's hard
That's the problem. So what we had to do initially, because we were starting with Cerner at the same time when we started staffing the clinic, we had to free text it. And then there are only few pharmacies in a particular area that will have it available. Most of the times a specialty pharmacy, and the CF Foundation has actually their own specialty pharmacy where you can just get the inhaled Tobramycin, the Pulmozyme, and everything. But then it becomes an issue between insurance and the pharmacy and agreements. But it there should be available. It's not built up usually in the order set from Epic or Cerner, but it should be available.
I think it's not available in the hospital for patient.
Yeah, that depends on, because we don't see that many patients with CF. I don't know. If you buy a lot, it will expire before you can use it. So, okay, bronchodilators, they're considered routine care. However, there is no trial or study evidence. If you're going to use them, use beta agonists. Never use anticholinergic because of thickening more the secretions. So far, any questions on pulmonary clearance therapies? Okay. Antimicrobials. You had a question? No? Good.
Yes.
Yeah.
So you show all the different devices or techniques.
Mm-hmm.
Is any specific one recommended over the other? Like
No, they are all considered equally effective, and it's basically a matter of patient preference. Many patients have all different preferences and ease of use, because the session with the vest, for instance, only the vest is 20 minutes. And if you put into account that they have to use the albuterol, Dornase, hypertonic saline, and if you count that each one of those nebulizations take 10 minutes, their treatment becomes roughly an hour. So as years go by, they get a little bit more skeptic, and they try to get what gives them the most with the least amount of time invested. The main issue we had particularly was the kids that were going from high school to college, because in high school, most high schools have the nursery and they can go there and they get their treatments. College, there is no place for you. So they ended up either dropping from college or dropping their FEV1, because there is no logistic for them when they are going to college. But it's personal preference. Okay, antimicrobials, as you guys probably know, this is one of the big issues, the chronic infection. And when we start seeing them at this age, 18 to 24, the majority of them will have Pseudomonas. And, Pseudomonas is this one, the peak. And this is a staph coming down, but the MRSA, it's usually on the rise when we see them in the transition phase. This is important because the rationale is, first, whenever you have a patient with CF that their culture shows Pseudomonas for the first time, you need to work to eradicate the Pseudomonas. So these are patients that may get up to 4-6 weeks of IV antibiotics with the hope that you will eradicate them. How often that happens? Very seldom. They just continue to have the chronic infection. But also, they developed the antimicrobials to try to decrease the bacterial load in your airways. The ones that are approved are Tobramycin and Rationale.
Enrique?
Yeah.
What about cepacia?
Cepacia, it's seen more commonly in these patients. I think it's around less than 10% of them. It's just a marker of poor prognosis. So their mortality, I'm blanking on the number, but I think their mortality risk doubles after a year of having cepacia. And many centers will not give them transplants if they have cepacia. So everything, your survival went down, and your chances of getting a transplant become slim, because few centers will transplant patients that have cepacia. But there is no particular treatment for eradication so far recommended. Many centers may do it. I don't recall trying that.
Oh, one other question. Do they still, I remember when I was at the DMC, they sometimes were starting, when they have like these camps. If you had cepacia, you went this time. If you didn't have cepacia, you went at a different time. So you try to keep them separate from the other.
Yeah, I think they stopped doing those camps actually, because there was a lot of infection or transmission during those camps. So I think as far as families and patients used to go to the CFF conference, that's not recommended anymore. those infectious issues. So basically, just an overview to tell you that patients that with Mucoid Pseudomonas tend to do worse in terms of PFTs and overall prognosis. So they deteriorate faster than the non-Mucoid Pseudomonas. So another reason why they are very active about treating it. This is the inhaled Toby, 300 twice a day, and gray is the week on, and white is the week off. And you can see a sustained difference compared to placebo in terms of FEV1. And then these are just microbiological data in terms of the density of Pseudomonas, how it increases during the off month and the load goes down. So there is a correlation between the FEV1, your PFT, and the amount of Pseudomonas that you have in your airway. And similar data for the astronome called Keystone, the brand name. Better quality of life for the patient on Keystone. They have not been compared head to head. So we know that both improve your FEV1, decrease your Pseudomonas burden, and improve your quality of life. Most of the times what you do is you just alternate them, 4 weeks of Tobis, 4 weeks of Keystone. Few of them can tolerate that because of the way you handle things. One thing that I did not pay a lot of attention in fellowship apparently was the fact that the nebulized antibiotics should be given with a particular type of nebulizer. They usually get this through a jet nebulizer, and the trials were only done with one that is called the Pari LC, that's the brand name. So just for you to be aware, patients that are on inhaled Tobramycin, inhaled Keystone, even for the Pulmozyme, they need to be on the breath-enhanced nebulizer. I didn't know this, and I thought it was a good piece of information for everybody. I didn't know this before I started treating them. Astronome has its own device, the eFlow, which again becomes a burden because if you think about the way they do their treatments, changing the nebulizer for each medication, and this particular one, they have to boil some water for the container and whatnot. Bottom line, many times the burden is so high, many patients stop using it. They come up with any reason for that. There is a dry powder inhaler for Tobramycin that many patients consider very convenient, but some of them say it's like inhaling sand because it's really a huge load of powder. So many like them because it's convenient. Many of them hate it because the sensation of powder going to their lungs. Questions so far? I'm either confusing you too much or being too clear. Inflammation. There have been 3 families of medications targeted at inflammation in CF. Macrolides are the ones that have shown better FEV1 and less exacerbations. And it's particularly, I don't know, it doesn't make sense from the antimicrobial side. Why would you recommend azithromycin to every patient that has Pseudomonas in their sputum? But that's the indication. Chronic azithromycin for CF patients. So it's recommended for all patients with Pseudomonas and 6 years old and older. Steroids, none of them is recommended unless you have a different indication. For instance, many of these patients may have reactive airway disease if you suspect it. Then you're probably okay. The CF Foundation will not, because they have very strict quality criteria, and they will look at patients that are on inhaled steroids, and if you don't have justification for that, you're not meeting their quality criteria. So it's only used for asthma or sometimes ABPA. NSAIDs is beneficial, and the trials have been done in kids mostly, but But right now, for adults, which is what you may be asked in your boards, is not recommended. There is not enough evidence to recommend ibuprofen in CF patients. That doesn't mean it doesn't get used, but most patients don't like it because of the side effects. So, just as a summary, Class A recommendations: the Pulmozyme, the Tobramycin, the Rationale, and most recently, I missed that, the receptor modificators, the ORCAMP that we were talking about. Class B, macrolized bronchodilator and hypertonic saline. So pretty much this is what is recommended by the CF Foundation. Not recommended oral steroids, inhaled steroids, and not sure, not enough information. Oral steroids, anticholinergics, N-acetylcysteine, cromolyn, ibuprofen in adults, and anti-staph antibiotics chronically. So just a parenthesis there, the three pulmonologists, my two partners and myself that were in this CF program, none of us wanted to do CF. And basically we were forced to go there and start and seeing them. Just by adhering to these guidelines, nothing else, the mean FEV1 in the adults went up by 10%. So if you just adhere to this, you are safe. The patients do well. And basically what you need to do is assess if you need more medications, A, and B, be sure that they are using them. You have a question? Okay. One other thing that nobody tells you when you are in, reading about this is not in any books, is the order of the breathing treatments, okay? Which right now makes sense to me. So first of all, bronchodilators to try to open the airways, followed by hypertonic saline first to clear the thick secretions, and then the Dornase alpha, which supposedly needs longer time to work. Then the chest PT or whatever they use in terms of chest therapy to remove the most secretions possible, the most sputum possible. And then you give the medications that are supposed to stay in the system, which is the antibiotics and inhaled steroids, if indicated. Okay? Usual visit, as I said before, focus on the BMI, focus on your FEV1 and the number of exacerbations, and you should be fine. Why is that? So these are survival graphs. The first one is about patients with BMI of above 19 and below 19. You see the dramatic difference. The same goes for patients with FEV1 above 80% and FEV1 below 80%, and patients colonized with Pseudomonas. Not colonized, with chronic infections from Pseudomonas. So, again, one of the paradigms is the multidisciplinary nature of the care of these patients. The CF Center team, every country has different guidelines. This is what the CF Foundation has. Center director, sometimes a co-director, clinic coordinator, social worker, respiratory therapist, nurse, and a dietitian. And I think most of the work is done from here below. When we were in clinic, we saw the patients, we took care of them, but the legwork is done by them because they are the ones who coordinate all the care, insurance, medications, chest PT technique, everything else. So just, I'm sure you already know this, but the functions for each person, and actually this is the order where they see the patients before you get to the room. One thing that I forgot to mention, I didn't put in my presentation, but keep in mind that now the recommendation for these patients is they always get a mask when they get in the room, and they are always in contact precautions, even in the clinic. And there is only one room dedicated to them in the clinic. So these clinics run 8 rooms at a given day because you have 8 different patients scheduled. So everybody goes there first. Respiratory will tell you if the FEV1 is higher or lower, how are they doing their treatments, if they are unable to do X or Y treatment, and why is that. The same goes with the dietitian. They follow closely, mostly because of the enzymes, the malabsorption issues. Social worker and the coordinator, and then finally you get to see them. And with all that information, you can actually coordinate care better. You know, you have a better sense about why is the patient not using their treatments. Are they unable to afford them? They are just getting lazy. College is an issue. They never tell you about their social issues, but they tell everybody else. So I think it's very important for you to at least know how is it run, and these visits happen every 3 months. Yearly, you will check liver enzymes, vitamin levels, Ig level, and an AFP, just as a matter of surveillance. Of course, sputum culture gets done in every visit. Chest X-ray needs to be done yearly. I don't know why, but it gets done yearly. You do an OGTT, a screening for CFRD, the CF-related diabetes, and a PPD. And every 3 months, basically, if everything goes fine, you just need a spirometry and a sputum culture. You guys are probably aware of this, but the sputum culture based on the CF guidelines requires a specific processing, looking for microorganisms that are typical to CF patients, so they are incubated in a different way, and actually you need a certification by the CF Foundation to actually run a CF culture. So just for you to know, not every single sputum culture is the same everywhere. So far, any questions? For exacerbations, it's basically, to me as a pulmonologist, basically pretty similar to any COPD exacerbation. The things that you need to be more cognizant about is weight loss or a change in the FEV1. Sometimes a change in the FEV1 of 10%, the patient may be doing great. Most CF centers will admit the patients that drop the FEV1 more than 10%, admit them for treatment of an acute exacerbation. The focus is decrease the bacterial load with oral or IV antibiotics and increase your airway clearance therapy. So continue the same medications, and there is always the question about continue your inhaled antibiotics while in the hospital. And my take on that is, if they're on the cycle, I would just continue that. If they're off the cycle, I will not restart them. I basically want to keep them on the same cycle they are at home, so there is no confusion on discharge. Am I on the cycle? Am I off the cycle? They didn't continue. So I don't think of the inhaled Tobramycin as a treatment for the exacerbation, and it should be continued if the patient is in the cycle on the 4 weeks. In terms of hospital admissions, I just put this here because there were repeated interactions between the pulmonary team and the internal medicine residents when we admitted these patients, because there are particularities to these patients that are not done on every single medicine patient. These CF patients are taught since they are kids that not every day they need blood work, and they get really upset and frustrated if you order daily labs. So you try to tailor that as much as possible. So do not repeat the labs that are supposed to be done yearly if they have been done recently in the clinic. Chest X-ray is a given always. Sputum culture, if it was not done recently, repeat it. And the one thing that is important, many centers do a spirometry once or twice per week as an inpatient to follow the FEV1 as a surrogate of success of treatment. So that's something that is different from, say, from our COPD patients or asthma patients. Continue the home regimen, as I said before, antibiotics. So that's another thing. They always get a PICC line. And if your patient gets exacerbations 3-4 times a year that need IV antibiotics, many of them will have a port. So, and most of the time they will prefer to get the PICC line placed before they get blood drawn. They are pretty seasoned in the hospitals. Most centers use double coverage for Pseudomonas. That's important. And they use it for the full 14-day course. If the patient has Pseudomonas, most centers, as far as I know, will do double antibiotic coverage for Pseudomonas. Another particular issue is the dosing of the antibiotics. They can look small, thin, but they require a ton of antibiotics because of increased metabolism of the antibiotic and the need to get high levels to the secretions. So, for instance, if you see the cefepime, the adult dose is 2 grams every 8 hours, which we very seldom use in other patients with pneumonia. Meropenem, same 2 grams every 8 hours. Cipro, which is the one that we use the most as outpatient, 1 gram Q12 hours. So just keep that in mind if a patient like this comes your way. These patients tend to have diabetes, but don't restrict their calories. Their weight is a marker of how well they are doing. So most of the diabetic patients will get an ADA 1800, ADA 2000. These patients may get up to 4,000, 5,000 calories a day. Don't restrict that, because that helps them get through the exacerbation. So that's one of the big things we had in the hospital with the medicine residents. Like, no, give insulin as much as they need, keep the calories going. And it's also important to remember that many of these patients use tube feeds at night to keep their BMI high. Try to continue that as much as possible, and sometimes you have to, when they are admitted, they need a 24-hour feeding tube to try to increase the weight as much as possible. The order set usually was 3 meals and 3 snacks, remember that. And as I just said, never, the diabetes, the CF-related diabetes, never managed with caloric restriction, always adjust insulin in the home regimen. One thing that tends to be overlooked is their pancreatic insufficiency, so be sure that they're in the amount of capsules that they usually use at home. They usually know for a meal I use 6 capsules, for a snack I use 4. Be sure that that is given to them, because otherwise they just get a standard dose from the hospital, which is 2 with each meal, and then they develop diarrhea. Consider ABPA or non-TB mycobacteria if your patient is not responding to treatment or if they're having frequent exacerbations. But don't check for this every time the patient has an exacerbation, because they get in, every time you're on AFB, they get in their own respiratory precautions. Special situations, pneumothorax, remember, you may have to, they tend to have spontaneous pneumothorax, hold any type of percussion therapy for their clearance of mucus. I know it makes sense, but many times continues to happen. And hemoptysis, same issue, try to not percuse, because there is a theoretical concern that you may dislodge a clot and the patient may have recurring hemoptysis. And I think that's about it. I hope I didn't bore you too much. Yes, Jesse.
When would you consider transferring these patients to a CF center, and if there is any mortality benefit associated?
You mean in terms of exacerbation, or?
You have a patient and you're seeing a patient in clinic, and then you somehow diagnose them with CF.
Always. Always. The standard of care is they need to be seen at CF center. They can continue to see their community pulmonologist, but the quality from the CF Foundation is you need to be seen at your center every 3 months, 4 times per year. So always.
What about people with CF mutations, like variants? Like, we had a guy who got transplanted, he had children, he has siblings with CF, and he had bronchiectasis all the time, and he's been tested for it in the past, but he just had a variation of it. Treat them any differently?
So you mean they have one of the mutations, he has 2 mutations that are supposed to be benign? Yeah. Those patients, yeah, you should also send them to the CF center for.
The same way as far as the medication.
Yeah, if you have 2 copies of defective genes, and you meet the clinical criteria for cystic fibrosis with bronchiectasis or other organ involvement, you can diagnose it with CF, and they need to be treated as such.
What if, kind of like spinning off that question, what if you encounter these patients in the inpatient setting? Somebody who has a diagnosis of cystic fibrosis who goes to a non-cystic fibrosis hospital, would you consider transferring to a cystic fibrosis?
Not necessarily. Those are the patients that I think we can handle if we know how to treat them. So that's why I brought up that slide of don't cut their calories, give them a higher dose of antibiotics, work really hard on the nutrition. Many times you will get a phone call from the center saying transfer to us, but not necessarily.
Enrique.
My comments would be that we do see, everybody's, if you're, especially if you're in an academic center, every few years you'll come across somebody who has my experience has been, first of all, that there's a lot of different genetic variants, and it's a very heterogeneous population where you have some people who have a little bit of bronchiectasis, whereas you have some people that are approaching what looks like real CF. And if you go and look up the specific variant and about that specific patient, you're not going to find data. And so I would suggest that even at some CF centers, with some of these rare mutations, they're not going to have your patient and will not have seen it. So I think collaboration with the center is important, but I think that it requires you to take a very thoughtful approach to the patient, and depending on how invested you are in the kind of center you might be, if you're have an academic center, be the best person to manage that patient, because I think that you have to be very flexible in your approach.
Correct. It needs to be tailored. These were just general principles, but it's, as you said, it's very heterogeneous. I saw a patient that's 64-year-old. Her FE1 has remained 50% for 30 years.
30-year-old who's got real CF. They probably should be followed at the center. But if you've got the 64-year-olds with bronchiectasis and a rare mutation that you've diagnosed, deciding exactly what to do is going to be complicated.
Correct.
And the CF center is not necessarily going to do
And sometimes the CF center will say, you're doing everything great, we don't need to see her back again.
Yeah.
But the problem, the CF center has also competing interests, unfortunately, and one of them is meeting the standards of that CF Foundation tells them, and basically they are literally forced to see patients every 3 months, which doesn't happen most of the time in those patients that are doing well. So I think if that's a special individualized approach where you can just pick up the phone, talk to the person in the CF center and say, hey, can you see this patient once, be sure that I'm doing the right thing, and I will just carry on. That's also.
Right, Enrique.
Yeah.
When I was at the DMC at Hudson and at Harvard, we couldn't get a center set up like not that we wanted to, but the center was at the Children's. So if they needed admission to the hospital, because a lot of the people who were older didn't want to go to Children's Hospital to be treated. So they would be admitted to me at Harvard or either at Hudson, and with direction from the patient who really knew what to do and not to do, along with the guy's name who was at Children's, would give him the antibiotics, et cetera, close communication. When he got his antibiotics, we sent him back to the center. Because it was too hard to, when you're not set up for a system like that, it's just, you can't keep it up.
Correct.
But at least during the hospitalization, when they were there getting antibiotics, I can handle that, they felt comfortable being in an adult hospital. And we sent them back to them for all the other
stuff. I think, again, knowing the minor issues specific to their hospital admissions, I think you can handle their hospitalization well enough. And if you keep a close communication with them, they may give you an opinion about X or Y problem that you may be facing with a particular patient.
And most of the patients, they knew exactly what to do. They just go in the room and take the chart and say, okay, what do you need? And they would have it exactly that. Of course, I would communicate with the other doctor too. But they were pretty good.
They know. Yeah, they know. And they bring their guitar and they bring their Xbox and everything to the hospital.
I think one of the things I would struggle with is how much of this to try to translate to patients with non-CF bronchiectasis.
Yeah, I know.
So how much of any of this do you do in patients with bronchiectasis that's not from CF?
Honestly, I don't see a lot of patients with bronchiectasis, but for instance, patients colonized with Pseudomonas that I know they grew Pseudomonas and that have frequent exacerbations, I usually put on Tobramycin every 4 on, 4 off. That's one that I usually do. In terms of Dornase or anything like that, I don't think I don't underuse. But the main one that I personally, I don't think there is a right or wrong answer there. If you're colonized with Pseudomonas, then Tobramycin or Aztreonam makes sense. And other than that, the increased clearance therapies like flutter valve or vest, whatnot. Jesse?
I saw on your slide where steroids were not used for maintenance, but of course when we see some of these patients that we're looking and they're having bronchiectasis and they're wheezing, the standard would be steroids, but IV steroids were in your algorithm for acute exacerbation.
No.
So there's no IV steroids at all?
No, not at all. Again, every patient is different, and the patients that tend to get sicker are usually patients that have, for instance, ABPA. Okay? So, for instance, sometimes you're treating a patient with ABPA, you're trying to come down on the prednisone that they're taking for ABPA, and they get an exacerbation. In that situation, individualized situation, you're welcome to go up. If you're strongly suspecting ABPA, then measure your IgE and start the steroids if needed be, but not routinely. You will not give them steroids as we do, say, in COPD.
These patients that you saw in the clinic as a follow-up, what factors prompts you to refer them to transplant?
Good question. Like, you mean what are your triggers for transplant? Every transplant center is different about that. Personally, what I usually thought about was, okay, we dropped the FEV1 10% and we haven't gotten it back. That's one. Two, and it depends on your baseline FEV1. If your FEV1 is 80% predicted and you drop to 70, I think you still have room to work on things. If your FEV1 dropped from 40 to 30, that's your alternative. I had a patient on 50% predicted, but she was in the hospital every other month. We sent her for transplant, and they actually transplanted her at, I think it was UVA, within a year. So it's basically the frequency of exacerbations and how your PFTs are doing. The ones that we successfully made transplanted there were the ones that had drop in FEV1 and were in the hospital pretty much all the time, despite good therapy, and not colonized with NTM or Cepacia. Cepacia was the kiss of death for them. Good? Anything else? Okay.